This is a 58-year-old female patient who presented with acute cough, fever, and shortness of breath. This case is mainly directed for seniors, but I'll explain a few basic concepts so juniors could take something out of it. This is a high-resolution chest CT. On such a chest CT, the lungs should appear dark, apart from the white of the vessels. You could also identify the white circles that represent the wall of the small airways. This means that this area of whiteness here is abnormal. And this is what we call airspace disease. So an area of increased lung density is called airspace disease. If airspace disease obscures the underlying lung markings, this is what we call consolidation. If airspace disease, which means increased lung density, does not obscure the underlying lung markings like what we see here, this is what we call ground glass opacity. Now it's much easier to understand that you have what's called ground glass opacity. If you describe the location of the abnormality, you'll do fine. Now that you decided that ground glass opacity is the main abnormality, mention whether the abnormality is unilateral or bilateral. It's obvious here that the abnormality involves both lungs, so this is bilateral. Now talk about the location. You have to decide on the predominant location. By that we mean you have to decide if the abnormality is upper versus lower or central versus peripheral in location. Sometimes the abnormality is so diffuse that you cannot decide, but in this case the decision is easy. Let's go over this. Let's take this left lung for example. You notice that the abnormality is predominantly peripheral. It's adjacent to the pleura. If you go lower down, the same exists. The abnormality is discontinuous, and that's what we call patchy in distribution. So it's peripheral and patchy. The same is happening on the right side, where you have peripheral patchy ground glass opacities. Remember that the pleura engulfs the lung laterally and medially, so even these opacities that are more towards the medial aspect are also peripheral and subpleural. Despite the peripheral distribution, you also have some patches that are more central in location. But if you look closely, these patchy ground glass opacities that look more central are surrounding the hilum and the central vessels and airways. Scrolling up and down, you see how this ground glass opacity area involves the region surrounding the blood vessel and the related airways. And this is what we also call a peribronchovascular distribution. Whenever you think about a peribronchovascular distribution, try to look at the coronal image, where this distribution is much easier to appreciate. So here you have these patchy opacities that are surrounding the peribronchovascular structures on either side. The coronal image also makes it easier to appreciate if there is a craniocaudal distribution. By that I mean if there is predominance in the upper versus the lower lungs, and you could tell here that the lower lungs are more involved. Just scroll back and forth to give you a better appreciation of the slight lower lung predominance. So putting everything together, you have a bilateral patchy ground glass abnormality in peripheral, peribronchovascular, and lower lung predominance. And this opens up a more advanced discussion for seniors. Whenever you have that kind of description, you're talking about organizing pneumonia. For the more junior followers, organizing pneumonia does not necessarily mean an infection. There are a few confusing concepts about this organizing pneumonia thing. One of the confusing things is the term pneumonia, where people think it's always an infection. So, first of all, let's agree that organizing pneumonia is purely a non-specific inflammatory reaction of the lung. A simple way to think about organizing pneumonia is to think of it as a non-specific inflammatory reaction such as an ESR. When you order a blood test and the ESR is elevated, the only thing that tells you is that there is something wrong with the patient. It does not give you a diagnosis, but it tells you that it's an inflammatory marker that might mean an infection, inflammatory conditions, neoplasms, and others. So think about organizing pneumonia as the ESR of the lung. So this non-specific reaction of the lung that we call organizing pneumonia could be idiopathic, which we call primary, or may result from a known cause, which we would call secondary. When organizing pneumonia is idiopathic, that's what we call cryptogenic organizing pneumonia. Cryptogenic means idiopathic. Cryptogenic organizing pneumonia, or COP, is an idiopathic condition that is typically subacute to chronic. And the patient may have cough, fever, shortness of breath, but in a chronic fashion. Cryptogenic organizing pneumonia is rare. You're not going to see it every day. What's nice about cryptogenic organizing pneumonia is that it's a disease that strikingly responds to steroids. So if you give the patient steroids, he improves in a dramatic fashion, and that includes even imaging improvement as well. Another confusing concept about cryptogenic organizing pneumonia is that it used to be called bronchiolitis obliterans organizing pneumonia, BOOP. However, many authors would discourage using that term since this does not really reflect what happens in pathology. Despite of that, many clinicians in practice would still either call it COP or BOOP. Now let's go to the secondary type of organizing pneumonia, the type that happens due to an insult. This type is way more common than the idiopathic form that we just talked about. A very long list of lung insults may lead to organizing pneumonia. However, the common ones to remember in practice would be secondary to an infection, to connective tissue disease, to rejection after transplant, and to drugs. And this form of secondary organizing pneumonia may be acute, subacute, or chronic. In such case, you have to treat the cause of the organizing pneumonia, and sometimes adding steroids might help. Now this is very important for senior residents, and it's something that they may be confused with all the time. Remember that imaging organizing pneumonia may yield different appearances. It could be unifocal, multifocal, unilateral, bilateral, consolidations, ground glass, or even look like a mass. The only reason where you'd suggest organizing pneumonia if you have a chronic opacity that's not resolving, or if it has a typical distribution. And the typical distribution is what you see here: bilateral, multifocal, patchy ground glass opacities or consolidations in peripheral and peribronchovascular distribution. And the disease commonly has a lower lung predominance. Now, to reach the diagnosis, let's put everything together. This is an organizing pneumonia appearance in a patient who presented acutely. And this turned out to be organizing pneumonia secondary to an acute viral infection, which resolved spontaneously. The subsequent follow-up imaging on the patient revealed normalization of the lungs without even administration of steroids. The final diagnosis here is organizing pneumonia secondary to a viral infection. Let's revise what we learned today with a few concepts that are good for both seniors and juniors. First, an airspace opacity is increased lung density. If it obscures the underlying lung marking, it's a consolidation. If it does not, it's ground glass. Second, when you have an abnormality in the lung, decide on the predominant distribution. Is it unilateral versus bilateral? Is it upper versus lower? And is it central versus peripheral? Third, organizing pneumonia is a non-specific reaction to insults, which may be idiopathic. The idiopathic form is called COP. It's typically chronic, and it responds dramatically to steroids. The secondary type may be acute, and is due to many reasons, commonly infections, connective tissue disorders, drug reactions, and rejection. With secondary organizing pneumonia, you treat the cause. Steroid may or may not play a role. Fourth, organizing pneumonia has various appearances. The one that would suggest the diagnosis is what you see here. The typical appearance is multifocal bilateral airspace opacities in peripheral, peribronchovascular, and basilar distributions. That's it for today's case. I'd always appreciate your comments and feedback. If you think this account or the other Radiology Bits accounts are useful, I'd also appreciate if you spread the word about them. And by that I come to my famous sentence. Thanks for watching. See you with more cases later. This is a 63-year-old male patient who presented with a decreased level of consciousness. Although this case evolves around a topic that we have discussed before, I think this is extremely important to show again. Today's case is aimed at juniors. This is because I had several requests from students, interns, and junior residents to talk about some of the more basic stuff. And I believe this comes at good timing since we have lots of new first-year residents starting this week. So today's case is one of the bread and butter on-call cases that you have to know about before starting your duties. As for senior followers, don't worry. The next case I'll show this week is an advanced case that I hope you'll like. Before we discuss this abnormal case, let's talk a little bit about basic normal anatomy. This is a different case which is normal. The first thing we're going to agree on is that you have gray matter and white matter. On a normal CT scan, the gray matter or the cortex appears bright while the white matter appears dark. So it's the reverse of what you expect. The darkest thing you'd see on a CT scan is that of fluid, namely CSF. So this is CSF that you see here in between gyri. From our normal anatomy, we know that the brain has an undulating surface, and each undulation here is called a gyrus. And you see these dipping cliffs of CSF in between gyri, and this is what we call sulci. Although you have gray matter on the surface of the brain, which we call cortex, you still have gray matter within the brain, which we call the deep gray matter structures. I'll discuss these structures in detail in another clip. For today, we're going to skip that. Another important structure that is relevant to today's case is this line here. And this is a tough barrier separating both hemispheres. This is what we call the falx cerebri. Now, a good chunk of the brain is located in the anterior and middle cranial fossa, and that's why this is called the posterior cranial fossa. In addition to the falx cerebri, there is another tough membrane that separates the posterior fossa structures from the rest of the brain. This is part of the right and left membrane, which is called the Tentorium cerebelli. Since this tentorium has a transverse orientation, it's more difficult to see on these axial images. The tentorium is much easier to see in the coronal image. And this is your tentorium in red, separating the supratentorial brain from the infratentorial brain. It's also easy to see the falx on the coronal image. You see it here in green. I'll scroll back and forth just to give you an idea about the falx and tentorium. To understand what we're going to show in the abnormal case, you need to know that the density of structures on CT is extremely important. Bright material on CT, or what we call hyperdense, typically represents calcium, bone, or acute hemorrhage. Here you see the brightness of the skull, and that's bone. Here you see some normal calcifications within the brain, which we'll talk about in another section. And of course, on this relatively normal case, you don't see brightness that suggests hemorrhage within the brain. You can change the window to appreciate structures in different ways, and this is what we call a bone window, and that's why you see the bones in a better way than before. What I really want to show you here are these zigzaggy, well-defined lines that separate different bones of the skull. And those are sutures. For example, this is a suture that separates the frontal from the parietal bone. You'll have to know the normal sutures and do not confuse those with fractures, and we'll talk about how to do that in the future. But for now, remember that you have sutures, and this is relevant to what we're going to talk about with the abnormal case, so keep that in mind. This is the CSF filling the ventricular system, which we talked about in details before. But there's one structure I want to emphasize here. There's this midline membrane that separates the frontal horns of the lateral ventricles, and it's called the septum pellucidum. So remember, the septum pellucidum is another midline structure that I need you to know for now. Now that you know the gyri, sulci, falx, tentorium, septum pellucidum, and sutures, we could proceed to the abnormal case. Compared to the previous case, you see this abnormal hyperdensity, and we know that one of the causes of hyperdensity would be blood. The two types of acute bleeding within the brain is inside the parenchyma, which we call intraaxial, or what's inside of the skull but outside of the brain parenchyma, which we call extraaxial. When it comes to extraaxial bleeding, you have three types: subdural hematoma, epidural hematoma, and subarachnoid hemorrhage. Subarachnoid hemorrhage is hemorrhage that fills the subarachnoid CSF spaces such as the sulci, and here you don't see any blood filling those. However, the two types that are commonly confusing for beginners are the subdural versus the epidural hematoma. When you see an extraaxial acute hematoma such as this, you have to decide if you're looking at a subdural versus epidural one. To understand that, let's talk a bit of anatomy that we know from before but is difficult to see on imaging. The meningeal anatomy, as we know from inside outside, is the pia mater, arachnoid, and dura. So the most external membrane is the dura, and this dura is tightly stuck to the bone. It's adherent to the bone. And epidural hematomas, as the name implies, epi means above or out, happens outside of the dura, meaning that the blood occurs between the dura and the skull in a very tight space. The typical cause is trauma that is commonly associated with a skull fracture, and the injured structure is an artery there. Remember the sutures seen better on bone window, such as this suture here. Since the dura is stuck to the bone of the skull, the epidural space where blood may collect is confined by these sutures. So if you have an epidural hematoma, the blood would respect sutures. It does not cross them. If you look here, the hematoma is not respecting the suture location, and this tells us that this is not in the epidural space. Because it's an artery in the epidural hematoma that's injured and it's bleeding quickly, add to that there is respect for sutures, the shape of the epidural hematoma would be different than what we see here. It would have a more biconvex appearance, or what we call lentiform. So an epidural hematoma looks like a lens, somewhat like this, which is not what we see on the right-sided abnormality. So remember, epidural hematomas are confined by sutures. They're typically arterial in nature, and they have a lentiform appearance, none of which we see here. Now, what about subdural hematomas? With subdural hematoma, the blood is collected inside of the dura and outside of the arachnoid, so between the arachnoid and dura. And that's why such bleeding as what we see here is not confined by sutures. However, the space is confined by the falx and tentorium. So a subdural hematoma, despite crossing sutures, does not cross the falx or tentorium. And since it's not confined by sutures, it has this different shape, which is a shape that confines to the curvature of the brain. So it has this half-moon or semi-lunar appearance. And as you go lower down, notice how this bleeding is confined in the supratentorial space. It does not extend to the infratentorial posterior fossa. So putting everything together, it has a semilunar shape that does not respect sutures but respects the falx and tentorium, and this is a subdural hematoma. Now this is more commonly seen in older patients where the brain decreases in volume and atrophies. And with such volume loss of the brain, that gives you more space between the skull and the brain where you have some bridging veins. In such patients, minor trauma or a quick shift in movement may lead to disruption of these bridging veins and the occurrence of subdural hematoma. Since venous bleeding is slower than arterial bleeding, such cases may present acutely or even chronically. Any lesion inside of the brain that causes significant mass effect could be considered urgent. However, epidural hematomas are very urgent. Remember that the cause of bleed with epidural hematoma is classically arterial in a very confined space. So such an epidural hematoma may progress very quickly and lead to very serious effects. So remember, epidural hematoma, quick arterial bleed in a confined space compared to subdural hematoma, slower venous bleed within a larger space. As I just mentioned, if you see any mass lesion in the brain, you have to decide on the mass effect it's exerting. I will not discuss all the herniation syndromes that you could see inside of the brain, but I'll talk about one very important condition. Notice how that this hematoma exerts mass effect on the right side. You cannot see these sulci as compared to the left side. This is called Sulkin Effacement. Also notice how the gray matter and its junction with the white matter is displaced anteriorly. Now, one of the most important things you have to mention in your report, if you're on call, is to decide if there is significant midline shift. And one of the easiest way to assess the midline shift is to decide on where you see the falx at a level where you could see the midline structure that we call the Septum Pellucidum. Connect the falx anteriorly by that posteriorly. Then measure the distance from the displaced Septum Pellucidum to the midline. And you see here that the patient has a substantial midline shift by a degree of about 7 millimeters. Since we have this tough falx that we talked about, what's really happening is that the displaced brain is sliding underneath the falx. That's why another name for midline shift is termed subfalcine herniation. So this is a right-sided acute subdural hematoma that is associated with substantial midline shift or subfalcine herniation. Now let's revise what we talked about today. We learned that on a CT scan, gray matter is white and white matter is gray. We also learned about gyri and the dark separating CSF-filled sulci. We talked about the midline falx and the other tentorial membrane that separates the supra from the infratentorial brain. We also knew about something called the Septum Pellucidum, another midline structure that, if you know with the falx, could help you measure the midline shift. We talked about assessing sutures on bone window. We also learned that bleeding inside of the skull could be intraaxial within the parenchyma or extraaxial outside of it. Extraaxial bleeding is subarachnoid hemorrhage, subdural hemorrhage, and epidural hemorrhage. When you see a bright finding on a CT scan that is not bone, calcium, or metal, this is likely hemorrhage. Today's case is a subdural hematoma that is differentiated from an epidural hematoma by several clinical and imaging points. Subdural hematomas occur because of disruption of bridging veins in the space between the arachnoid and the dura. The oozing of blood, because it's venous, is typically slower than compared to that of an arterial bleed. Subdural hematoma does not respect sutures, but it does respect the falx and tentorium. It has a semilunar shape, and it occurs in elderly patients more commonly because of volume loss. All of that is compared to an epidural hematoma that occurs usually due to trauma in younger patients. It has a lentiform appearance that respects the sutures. It does not respect the falx or tentorium, and it's considered a more urgent condition because of the quick arterial bleeding. That's it for today's case. I'll leave you with one question. What is considered the typical clinical presentation of an epidural hematoma? You may answer this on Snapchat or on our future YouTube clip. If you find this useful, please don't forget to spread the word or support us on Snapchat, YouTube, Twitter, and other platforms. And by that, I thank you for watching, and I'll see you with the senior case later this week. This is a brain MRI on a 2-year-old female patient with a clinical requisition stating the following. Ophthalmologic examination revealing an optic disc pit. As promised earlier this week, our last case of the week that we're showing here is a case that's advanced for seniors. However, before we proceed, for a junior audience, MRI is not a bad way to look at the orbits. We can use various sequences that we talked about before, T1 where fluid is dark, T2 where fluid is bright, contrast-enhanced sequences, and fat-saturated sequences. You can also look at the orbital components in sagittal, coronal reformats as well, which adds more information. So let's take this sequence, which is an axial image on T2. As you see, the CSF is bright and the fluid in the globe is bright. With the MRI, you could see the orbital globe. You could see the very dark lens here. This is the orbital cone behind the globe here. It has this cone-shaped appearance, and that's where the name comes from. And this space behind the orbital globe is filled with fat, and note how the fat is bright in a different way than CSF. That's why when you suspect lesions that may contain fat or may be obscured by fat, you could do a fat-suppressed sequence. You remove the fat from the image. This tubular structure that goes from within the brain into the cone is the optic nerve that attaches to the globe. Just scrolling up and down to show you how this nerve attaches to the globe. And this area of attachment clinically is the optic disc. The cuts that I'm showing here are thick cuts from a brain MRI, but if you do dedicated thinner cuts over the orbit, you may see more. The optic nerve is covered by meninges and is surrounded by a small amount of CSF. That's why this is technically called the optic nerve sheath complex. If you had thinner cuts, you could see the optic nerve, you could see the CSF surrounding it, which is usually a small amount, and you could see the meninges. And now you understand as a junior how the optic nerve is surrounded by CSF that's connected to the CSF inside the brain. And now it's more understandable why papilledema, where bulging of the optic nerve disc occurs. That's because the CSF within the brain increases in pressure and thus transmitted into the CSF around the nerve itself. Now there are more anatomical details that we could talk about when we discuss imaging of the orbit, but let's go to the most important finding here. Compare the right orbit with that of the left orbit. The reason I'm showing the case is mainly this here. At the area where the optic nerve sheath complex attaches to the globe, you have this dilatation. It's difficult to assess this area of focal mass-like appearance on the basis of thin cuts alone. However, compare that to the normal optic nerve sheath complex on the right side, you don't see that. To see this better, I'm going to show you dedicated thinner cuts sagittal imaging of both orbits. We'll start with the normal right side. You could see the CSF that's bright and surrounding the darker optic nerve here as it approaches the globe. And this image is performed with fat saturation. That's why the fat in the cone is black here. And on this image, which is a T2 where fluid should be bright, now you could better appreciate the fluid surrounding the optic nerve. Compare the bright fluid in the optic nerve to that in the globe itself or in the CSF inside the brain. So on the right side you have a uniform optic nerve exiting the brain to go into the cone and to attach to the globe. Now let's look at what we thought is abnormal on the left side. So this is the left side in sagittal T2 weighted images. You see the optic nerve here, and you see dilatation of the CSF containing space around it. Remember, this is a fat saturated image, so fat is dark and depressed, and this is not. And this tells you that this could be fluid. And to confirm that this is fluid, let's look at it on a T1 axial image where there's no fat saturation, so the fat is bright. And as you see here, the area that we suspected as being cystic or fluid dilatation is equal in density to the CSF, so it is fluid. One more thing you could do to make sure that this is not part of an enhancing neoplasm is to look at the intravenous contrast enhanced acquisition. And this is a T1 with contrast where the optic nerve enhances a little bit normally, and the cystic space here is not enhancing at all. Now here's what I learned from this case, and I think senior residents would also learn something new from this since we don't face this every day. A clinical request stating an optic disc pit means that the clinician discovered something unusual on examination. The pit represents itself as a focal depression at the optic disc, where the nerve joins the globe. And this depression to the clinician may have some different color than the normal optic disc that they usually see with ophthalmological examinations. An optic disc pit is a congenital and rare finding. It's most commonly unilateral, but it could be bilateral, and it's usually a finding of no clinical significance. However, some people think that in rare occasions, this optic pit may lead to retinal detachment and visual impairment. A less known but definite association of optic disc pits is optic nerve cysts. It is also thought that these cysts are incidental and of no clinical significance, but in some conditions they may compress the optic nerve. In that case, this becomes important. The visual impairment may be actually due to optic nerve compression by the cyst itself. In the very few cases that were reported in the literature, the suggested treatment in such case would be surgical or CT-guided fenestration or excision of the cyst. However, there are no reported cases where this was done, since the risk is theoretically a bit high to injure the optic nerve itself. So let's summarize what we talked about today. For juniors, you could look at the orbits using MR using the same techniques we talked about with the MRI of the head. You could do multiple planes, you could do T1, T2, with or without fat saturation. You could also give contrast. For juniors, if the clinical request is an optic nerve disc pit, look for an optic nerve sheath complex cyst. Well, that's it for today's case. Thanks again for watching. Please share your thoughts and comments, and see you with more cases later.